Okay, class. Today, the topic that you have to learn is about cavernous sinus thrombosis. Now, what is the learning outcome of this? We'll be able to comprehend the anatomy and the venous connection, and you'll be able to explain the danger area of the face. You will also be able to explain the spread of infection from the face, and you'll be able to list the etiology and the clinical features of sinus thrombosis. You'll also be able to point out the complications and the management of cavernous sinus thrombosis. Okay, so now cavernous sinus thrombosis is a rare, life-threatening disorder that can complicate facial infection, sinusitis, orbital cellulitis, or following traumatic injury or surgery, especially in the setting of a thrombophilic disorder. Cavernous sinus thrombosis is a serious condition. It causes death in up to 30% of the cases. Early recognition of cavernous sinus thrombosis is critical for a good outcome. Despite modern treatment with antibiotics and anticoagulation, the risk of long-term sequelae such as vision, diplopia, and stroke remains significant. Cavernous sinus thrombosis is the formation of a thrombus within the cavernous sinus, which can either be septic in origin or aseptic. Now, what is a septic cavernous sinus thrombosis? It's a rapidly evolving thrombophlebitic process with an infectious origin, typically from the middle third of the face, sinuses, the ears, from the teeth, usually the maxillary teeth, or from any part of the mouth, affecting the cavernous sinus and its structures. Aseptic cavernous sinus thrombosis is usually a thrombotic process that is a result of trauma, iatrogenic injuries, or prothrombotic conditions. Now, let's look at the epidemiology of cavernous sinus thrombosis, which is so rare that incidence data is difficult to estimate. Cavernous sinus thrombosis comprises approximately 1% to 4% of cerebral venous and sinus thrombosis. Incidence is approximately 0.2 to 1.6 per 100,000 per year. So it looks quite rare, but like I mentioned earlier, it is quite a dangerous situation to be in. A male or female predominance in cavernous sinus thrombosis is uncertain because of little data that they have collected. More is more in children and neonates than in adults. The incidence and mortality may be decreasing, likely due to the availability and the use of antibiotics, and also we may have a better understanding of it. Now, cavernous sinus thrombosis is usually septic, but can also be aseptic. Septic causes are like the facial abscess or cellulitis on the face, sinusitis, especially of the sphenoid and of the ethmoid bone, odontogenic origin, especially from the upper jaw region, or maxillofacial surgery, or otitis media, or from the mastoid bone being infected. Aseptic causes less common than septic causes. And examples and aseptics in trauma, surgery, or in pregnancy. Odontogenic sources have been reported to be responsible for up to 10% of the cases. The most commonly isolated organism are Staphylococcus aureus, which is about 70%, and Streptococcus species, which is about 20%. Other organisms include pneumococcus, bacteroids, Fusobacterium, Proteus, Haemophilus, Pseudomonas, and Corynebacterium. Bacteria stimulates the formation of a thrombus by the release of a procoagulative substance, and through toxins that cause tissue damage. This results in the formation of a thrombus, which propagates further in the system. Now, what are the risk factors involved that should be aware of? Things like immunosuppression, such as uncontrolled diabetes, the use of steroid, cancer, or in chemotherapy patients. Facial infections include acute sinusitis and periapital infections, that means infections around the eye. Pregnancy, postpartum, or receiving oral contraceptive hormones or hormone replacement therapy, which is commonly called HRP. Thrombophilic genetic disorders, example factor 5 Leiden's mutation, prothrombin G 2021 OA mutation, antithrombin 3, protein C and S deficiency, or increased factor 8. These are also the factors which are of risk to cause cavernous sinus thrombosis. Also, factors acquired disorders such as anti-phospholipid antibody syndrome, hypomyosystemia, heparin-induced thrombocytopenia, obesity, and severe dehydration such as in hyperosmolar non-keratotic state, nephrotic syndrome, and sickle cell disease can also be considered as risk factors. The anatomy of the cavernous sinus, which are located in the middle cranial fossa, is as shown in the diagram. On either side of the sella tussica of the sphenoid bone, which contains the pituitary gland, are the cavernous sinus region. They are enclosed by the endostele and meningeal layers of the durameter. Look at the diagram, you'll be able to see, and there's a picture of a face there. It shows you the danger area is from the right corner to the left corner of a line drawn and going upwards as a triangle to meet at the apex of the bone, apex of the nose, sorry. The borders of the cavernous sinus anteriorly is bounded by the superior orbital fissure, posteriorly the petrous part of the temporal bone, and in the medial boundary is the body of the sphenoid bone. The lateral boundary is the meningeal layer of the durameter running from the roof to the floor of the middle cranial fossa. The roof is from the meningeal layer of the durameter that attaches to the anterior and middle crinoid process of the sphenoid bone. The floor of the cavernous sinus thrombosis is made of the endostele layer of the durameter that overlies the base of the greater wing of the sphenoid bone. Now, having known the boundaries of it, now let's see what are the contents of the cavernous sinus. Several important structures passes through the cavernous sinus to enter the orbit. They can be sub-classified by whether they travel through the sinus itself or through its lateral wall. Let's see what are the contents that travel through the sinus itself. One is the abducens nerve, which is the cranial nerve 6, and also the carotid plexus, postganglionic sympathetic nerve fibers. And then you have the internal carotid artery, which goes through the sinus, the cavernous part of the internal carotid artery. Now, what are the structures that travel in the lateral wall of the cavernous sinus? There is the oculomotor nerve, cranial nerve 3, then you have the trochlear nerve, cranial nerve 4, and you have the ophthalmic and the maxillary branches of the trigeminal nerve, which is cranial nerve 5. This is the diagram showing you the structures. Cavernous sinus is the only site in the body where the artery internal carotid passes completely through a venous structure. This is thought to be so that there is a heat exchange between the warm arterial blood and the cooler venous circulation. I would like you to mind that it's a thought, may not really be the heat exchange, but it's a thought. So we have the diagram showing you the structures in the sinus. So to remember this, we use a acronym as OTOMCAT, where OTOM represents the oculomotor nerve, trochlear nerve, ophthalmic branch, maxillary branch, which refers to the lateral wall contents from superior to inferior, and CAT refers to internal carotid artery, abducens nerve, and trochlear nerve, which refers to the horizontal contents from medial to lateral part. Now, let us look at the dural venous sinus system. Each cavernous sinus receives venous drainage from ophthalmic veins, the superior and inferior. These enter the cavernous sinus via the superior orbital fissure. Then you have the central vein of the retina, which drains into the superior ophthalmic vein or directly into the cavernous sinus. Sphenoparietal sinus empties into the anterior aspect of the cavernous sinus. Superficial middle cerebral vein contributes to the venous drainage of the cerebellum. And the pterygoid plexus, which are located in the infratemporal fossa, also drains in the sinus. It's important to note that the superior ophthalmic vein forms an anastomosis with the facial vein. That means they interconnect. Therefore, the ophthalmic veins represent a potential route by which infection can spread from extracranial to intracranial. Intracranial, ophthalmic veins, and then the other one is facial veins. So they communicate. Cavernous sinus empties into the superior and inferior petrosal sinuses and ultimately into the internal jugular vein. The left and right cavernous sinuses are connected in the midline by the anterior and posterior intercavernous sinuses. They travel through the sella tussica of the sphenoid bone. This is diagram shows that you can see the ophthalmic veins and the facial veins, they communicate and they go into the cavernous sinus. Okay, this is what is shown on the left side of the diagram. Similarly, also is accurate mirror image on the right side. And they are connected both sides, left and right, by the intervenous sinus. Okay, then you have the superior petrosal sinus and you have the inferior petrosal sinus. And then you have the internal jugular vein and you have the transverse sinus. This is a schematic of the dural venous system relating to the cavernous sinus. Note the anastomosis between the ophthalmic veins and the facial vein. Now, this picture shows the danger area of the face, where it is. It's a triangle. If it's drawn as point on the left upper mouth and the upper right of the upper lip, making an apex at the bridge of the nose. It's a triangle, the yellow part. And this is schematic showing you the veins. Now, what are the clinical features that you can see if it presents in a patient to you who needs that treatment? He usually will be having unilateral retroorbital pain. And then there is periorbital edema, ophthalmoplegia, proptosis, chemosis, ptosis, exophthalmos, diplopia, and febrile. That means he'll be having fever. Now, what is the pathophysiology of it? Infection from the affected area, such as the danger zone of the face, can lead to embolization of bacteria and other infectious organisms which trigger thrombosis, which then can trap infection within the cavernous sinus. Cavernous sinus thrombosis leads to decreased drainage from the facial vein and superior and inferior ophthalmic veins, resulting in facial and periorbital edema, ptosis, proptosis, chemosis, discomfort, and pain with the eye muscle movement. Papillary edema, retinal venous distension, and loss of vision. Lack of valves in the dural sinus system allows blood through the emissary veins into and out of the cavernous sinus, and thrombus can propagate into the dural system. Communication between the right and left cavernous sinus via the intercavernous sinuses, anterior and posterior to the sella tussica, allows the spread of thrombus and infection from one side to the other side. Local compression and inflammation of the cranial nerves can lead to several partial or complete cranial neuropathies. First, you have diplopia from partial or complete external ophthalmoplegia due to compression of the sixth abducens nerve, the third oculomotor nerve, and the fourth trochlear nerve. Internal ophthalmoplegia non-reactive pupil occurs from the loss of sympathetic fibers from the short ciliary nerves, resulting in miosis, and from loss of parasympathetic fibers from cranial nerves oculomotor 3, resulting in mydriasis. Paresthesias around the eye, nose, forehead, and loss of corneal reflex from the ophthalmic nerve compression. Facial pain may arise, paresthesias or numbness from compression of the maxillary branch of the trigeminal nerve. So these neuropathies are due to the compression brought about by the inflammation around the cranial nerves in the sinus region. Septic cavernous venous thrombosis can result in central nervous system or infectious pulmonary complication. Dural venous and cavernous system is valveless. This venous blood can communicate with the dural sinuses and cerebral and emissary veins, leading to meningitis, dural emphysema, or brain abscesses. Infection can spread via the jugular vein to pulmonary musculature, resulting in septic emboli or abscess, pneumonia, or emphysema. Stroke can occur following carotid artery narrowing, vasculitis, or hemorrhagic infarction following progression to cortical vein thrombosis. Hypopituitarism can occur due to ischemia or direct spread of infection to the gland. Now, how do you diagnose a cavernous sinus thrombosis? We use computerized tomography or magnetic resonance imaging, which are the diagnostic modalities of choice for cavernous sinus thrombosis diagnosis. Okay, computerized tomography of the head, although not ideal for a cavernous sinus thrombosis diagnosis, can reveal several subtle abnormalities such as engorgement or dilation of the superior and or inferior ophthalmic veins. We could also be able to detect bulging of the lateral margins of the cavernous sinus. Or we could see an exophthalmos or possibility the presence of sphenoid and ethmoid sinusitis or a mass lesion near the sphenoid or pituitary gland. So all this we could be able to pick up in the CT scan. A contrast-enhanced MRI brain shows bulging of the cavernous sinus, increased dural enhancement, and absent flow void is seen. MRI is useful when CT images are not clear or when the infection has spread to the surrounding tissues, including the brain and the pituitary gland. Now, we have known the etiology, the causes, and now let's see how to diagnose, and now let's see what we can do for treatment. Appropriate therapy should take into account the primary source of infection as well as the possible associated complications such as brain abscesses, meningitis, or subdural emphysema. Surgical intervention should be directed at the primary source of the infection and the surrounding areas of the involvement. Incision and drainage of the involved sites should be accomplished as soon as possible. Emergent surgical drainage with sphenodectomy is indicated if the primary site infection is believed to be the sphenoid sinus. Likewise, the mainstay of therapy for cavernous sinus thrombosis is early and aggressive antibiotic administration, the use of IV cephalosporin, chloramphenicol, metronidazole. A broad-spectrum intravenous antibiotics are used as empiric therapy until a definite pathogen is found. How you get this pathogen? When you do an incision and drainage of the site, we culture the pus and we see what's the organism causing it. Steroids have a controversial role in the management of cavernous sinus thrombosis. The benefits of decreasing orbital inflammation, cranial nerve edema, vasogenic edema, and intracerebral hemorrhage must be weighed against the potential immunosuppressive effects and possible prothrombin properties by the use of steroids. Steroid therapy to reduce cranial nerve dysfunction or when progression to pituitary issue occurs. Corticosteroids should only be instituted after appropriate antibiotic cover. Anticoagulation with heparin after the diagnosis is confirmed. The benefits of the cessation of progression of the thrombus is the septic cavernous sinus thrombosis. Bacteria may reside within a thrombus for a period until canalization of the thrombus occurs following the penetration of the antibiotics. Complication. As the dural venous cavernous systems are valveless, communication between the dural sinuses and cerebral and emissary veins can lead to meningitis, dural emphysema, or cerebral abscesses. Propagation of infection via the internal jugular vein can result in septic pulmonary emboli, pulmonary abscesses, pneumonia, or emphysema. Compression of the internal carotid artery and pituitary gland may result in stroke and hypopituitarism, respectively. Last but not least, death could come about. Now, what's the prognosis? Before antibiotics were developed, the mortality rate of cavernous sinus thrombosis was almost 100%, that is, death. The development of antibiotics has decreased the mortality of cavernous sinus thrombosis. However, the mortality rate is still relatively high at 14% to 30%. This disease requires early diagnosis and proper treatment. Even after treatment, cranial nerve dysfunction may remain and intracavernous aneurysm may also occur. Therefore, long-term patient follow-up is imperative. And thank you very much for your attention.